So thank you for having me here today. We're talking about elder abuse, and the objectives are to understand why it is important, how to identify abuse, and what to do about it. About 1 million Americans are abused each year, 1 million Americans over 60. The incidence is about 11.4%, which includes self-neglect, but of course it's highly underreported, so we don't really know what the actual numbers are. So let's take the 78-year-old who is on warfarin or Coumadin, who presents for follow-up after missing several appointments. On exam, she has new bruises on her neck and ears. She reports that she often forgets whether she took her warfarin, and sometimes she takes a dose later than her usual time in case she forgot. You ask her about her safety at home with her caregiver, and she denies any mistreatment. True statements regarding this situation include which of the following? Mark all that are true. Do you think physical abuse is the most common type of elder mistreatment? Okay. The location of the bruises on this patient is very suspicious for physical abuse. Yeah, okay. Elder mistreatment reports have recently leveled off. No. Most reports of elder mistreatment come from physicians and healthcare providers. Okay. Approximately half of elder mistreatment cases are unreported. All right. So the location of the bruises in this patient are suspicious of physical abuse, and that's correct. And all the others are not, and that's because physical abuse is not the most common type. It's actually self-neglect, and then financial mistreatment is also more common. And then elder mistreatment is actually increasing in incidence, and we'll talk more about that in a minute. And then most reports come from family members, and many more than half are unreported. So in a study with patients on anticoagulants, no accidental bruising was on the ears, neck, genitals, buttocks, soles of the feet. So those are all suspicious areas. You can imagine if you fall on your knees or you bump your shin, but not your neck usually. In Wisconsin, the last report is from 2010. We don't have reporting since then, which is a reflection of the underfunding of our social services agencies in the state. And in 2010, there was actually a 0.6% decline in the Milwaukee area, which skewed the results, and that's because they didn't have enough funding to do the investigating and the reporting. So overall, there was a 5% increase in the rest of the state, and an 8.5% increase the previous year. So, by not having Milwaukee in the mix, probably skewed the results. So where does the data come from? We get it from the ICD-9 codes that are reported to Medicare, or now the ICD-10 codes. And the reporting is oftentimes inadequate, too, because when physicians code, or you as nurse practitioner will be coding, you will also have to put in the date and the occurrence and the location when you're coding these V codes and these E codes that were in ICD-9, and now in ICD-10 it's even more complicated. So oftentimes providers shy away from reporting these when they have 4 other diagnoses to bill for, and then that just drops to a lower rate, and then that's where we would not capture it then. But other reports are through Department of Social Services. The CDC also keeps reports, and if it's reported on the death certificate, it goes into the monthly mortality and morbidity report at the CDC, and then Medicare claims. So this is a website where to report abuse in Wisconsin that you have access to, because this presentation is posted. So the forms of abuse take on physical abuse, emotional, psychological, material, and neglect. The definition of physical abuse is willful infliction of harm to an older person, and it can include beatings, strangulations, or other physical constraint. Material abuse includes abuse of property or finances that belong to the patient, and can include deception, having the patient sign forms that they don't know anything about, and diverting funds. Then psychological abuse is causing mental anguish to the patient, but can include verbal abuse, harassment, intimidation, isolation. Keeping the patient from going to church, for example, would be emotional abuse or psychological abuse. So the wheel of physical, violent, and sexual abuse oftentimes consists also of the spokes of emotional and psychological abuse that are rooted in power and control. And they are all intertwined and interconnected. There is definitely an increase in the reporting of abuse, and probably a much greater increase in the incidence even. And it oftentimes has to do with the isolation that our families are living in now. There tend to be smaller families. Extended families oftentimes live far away. And with the recent economic downturn in 2008, that has added a lot more stress to families than what we had before. Many families rely on the Social Security check of the older person to keep the family afloat. Many older adults could not sell their homes to buy into a continuing care retirement community, for example, so they were forced to stay at home and rely on family members to help them, support them in the home. And neglect has a much higher prevalence in physical abuse. Oh, sorry. Okay, neglect. So that can be self-neglect, or it can be neglect from another person. I had a case that actually went to court, and we did a home visit on this patient, and the patient was taken care of by the great-nephew's girlfriend, who was in the home, and there were two small children, about 1 or 2 years old, in the home as well. And when we arrived at 11 o'clock, the girlfriend was still asleep in the living room, and the children were running around. The patient was in the back room and was curled up in the bed with a very strong-smelling diaper that when we changed it was very, very heavy with concentrated urine. We then gave her a glass of water to drink, and she drank the whole glass. We filled it up again, and she drank it again. So that's a positive glass of water test, what we call it. Elderly patients oftentimes don't feel thirsty because of apoptosis in the hypothalamus. So our thirst center is not functioning very well anymore. But when we take in water and the water hits the back of our throat, it gives our brain the signal, oh, there's water there, and now I'm thirsty, and then they'll down the whole glass. So that tells us that the patient was dehydrated when they drink down the whole glass of water. And so we contacted social service after this visit and spoke to the girlfriend, who was not very receptive to any kind of suggestions. And social services then opened a case, investigated, but pulled back, saying that has no actual harm been done. So they had to pull back out again. So a month later we came back, and this time we scheduled the visit for 4 p.m, hoping that the girlfriend would be awake by then, but found the same scenario. She was still asleep. The patient was curled up. The children were running around unsupervised. And the patient was still in a very heavy diaper, very concentrated urine, and again, downed 2 glasses of water in one sitting. So we contacted social services again, and they said, well, there's not really any harm done. So we kept doing home visits, and the patient was very stable, but was always just curled up in the bed in the back room and not communicative at all. She then developed some pressure ulcers, so we got home health in. They were treating the ulcers. They, again, reported the patient to social services. This way, they did an investigation because of the pressure ulcers, and that went to court. And that year, I was fellowship director of geriatrics at the time, and that year we had 5 fellows. So I took all of our 5 fellows with me to the court hearing, and it only went to the clerk of court. But when 6 doctors walked into the room, the lawyer of the great-nephew whispered in his ear and then told us, we will do anything that you'd ask us. So we requested the patient be placed in a facility, and within just a few weeks, she blossomed. She was up in the wheelchair, moving around, talking again. I mean, it was just a whole different person. So, that was neglect. Self-neglect is the most common type of abuse, and that's very difficult to tackle because, of course, patients have the right to do with their lives what they want to if they're cognitively intact. And if they're cognitively not intact, it's even more challenging to get them out of the situation because they don't have the insight that they're really harming themselves. And then second most common form of abuse is financial exploitation. So self-neglect is significant danger to themselves, to where they don't have adequate shelter or safety or food. And this is one form of self-neglect. And that's a huge fire hazard. If she were to turn on the stove, the whole house would burn down, Elders at risk are those that have had some generational conflict. And it tends to be that if the patient was abused by the parents, and oftentimes parents would spank children, but that also makes it more likely that that person then is being abused, because oftentimes then she also spanked her children and so on. And also the whole family dynamics revolves around that of power and control. And then there's oftentimes a lot of caregiver stress that goes into it, and we'll talk more about that toward the end. And then any kind of disability, whether if it's a lot of medical problems, functional disability, where the patient is dependent in a lot of ADLs and IADLs, and cognitive disability. Those are all that put patients at risk for elder abuse. Women are more likely to be victims, partly because we tend to live longer, and we are more dependent. We have more comorbidities, more functional decline as we age than men do. They're oftentimes more dependent financially, but also physically, and then patients at risk live oftentimes in isolation, don't have a lot of connections, not a lot of friends. Also, patients or caregivers who abuse alcohol or other substances are at higher risk of elder abuse. And then the older the patient, the higher the risk. When you look at this breakdown of the percentage of patients who are affected, considering that the older the patients, the smaller the number of patients, because patients die as we get older, then the high number of abuse in the 80 to 90-year-old group is really remarkable. And considering how few patients are over 90 years old, the over 90 group being that large is really significant. So the older the patient, the higher the risk, partly because of the dependency on functional status, but also on cognitive dependency, cognitive decline. Violence against women tends to increase in the childbearing years and then dip down in the perimenopausal years and then rise again with increasing age. Elders at risk, again, history of past intergenerational conflict, but patients who internalize blame and say, oh, it was my fault that this happened, are at higher risk too, and excessive loyalty to the family. Many times older adults are afraid to be placed in a facility, and therefore they don't want to speak up against their family that's abusing them, either financially, emotionally, or physically. And from the perspective of the caregiver, caregivers are at risk if they abuse substances or alcohol, if they have mental illness, if they're socially isolated and have poor self-image themselves, if the caregiver is young and immature, doesn't have a lot of knowledge or experience, and if there's somewhat uneducated and low literacy, that puts them at higher risk. If they're financially dependent on the check that the elderly patient is supplying, and if they don't have a lot of resources. I encourage you, when you go into practice, that you learn about the local resources that are available in your community, whether if it's the Alzheimer's Association, Alzheimer's Alliance in your community, the Senior Center, and so on. Take the first few weeks when you move into the community to just reach out, introduce yourself to the Senior Center director and say, I just want to learn a little bit what you offer so that I can refer my patients to you. They would be delighted to meet you. And you really become a better provider if you know the resources in the community. The most common abuser is a daughter, but it's closely followed by sons. And when you consider that 80% of caregivers are female, the high percentage of sons being abusers is really remarkable. And when you have a male caregiver, you've got to be very cognizant of the possibility of abuse. Definitely the majority of male caregivers do not abuse the older adult, but they're at higher risk than female caregivers. So have your antennas up. Likewise, the spouse, when you consider that more women are being cared for at home than men are, then it's really significant that the spouses make such a large proportion. It's, again, probably males. So red flags in the history of the patient. If you see the patient in the clinic, for example, or in the hospital, and the caregiver is either absent or will not leave the patient, is too hovering, those are all red flags. And trying to get to talk to the patient by themselves is oftentimes a challenge. And when I've had suspicions of abuse, then I will sometimes ask my staff, so for the next visit, when they come in, just knock on the door and ask the caregiver and say that they have a phone call for them. And while they're gone those 10 seconds, and then by the time they get to the phone, they can say, oh, they hung up. But those 10 seconds, I then capture and ask the patient, is there anything going on at home? And just try to screen for some abuse. When there is any delay in seeking care from the injury, that should raise a red flag. If there are injuries or bruises in different stages of healing, that should be a red flag. And if the explanation between what happened does not jive with the injury, If patients go from one doctor to another, if they tend to go to the emergency room more frequently or go to the hospital directly rather than following up with their primary provider, those are all red flags. If there's tension between the patient and the caregiver, that should also alert you to some suspicion for abuse. So if you, for example, reach up to get something from a shelf and the patient winces, that could be a sign that maybe they're being struck. If the caregiver is not assisting the patient appropriately, if they're saying, oh, the patient is just willfully peeing in her pants, even though she has end-stage dementia and just can't help it, those are all signs that there might be some misunderstanding that could increase the risk of abuse. If the patient does not know, if the caregiver does not know the medications or the history or the medical problems of the patient, that's also suspicious of at least neglect, if not abuse. Conversely, there is something we can do about it. Medications that can increase the stress for the family are, for example, diuretics that send the patient to the bathroom more frequently. Maybe we could scale back on the diuretics. Also, the dehydration that can come with the diuretic use can lead to confusion, delirium, and that can exacerbate the situation at home. Then psychotropic medications all increase the risk of falls. And, sometimes we have to use antidepressants, but at the same time they increase the risk of falls, and that could put more stress on patients. So look at the risk-benefit ratio and then weigh your options. Anticholinergic medications worsen dementia. Just think, dementia is a deficit of acetylcholine, and if you're using anticholinergic medicines, they block acetylcholine. What little acetylcholine is floating around, that increases the risk of delirium and confusion in patients with the risk of dementia. And then frequent dosing. Try to simplify the medication regimen. Are there medications they're taking 2 or 3 times a day that we could change to just once a day? Many medications are longer acting than we think and can be given just once a day. And do they have to be given in the morning and at night, or can they all be combined at night or in the morning? So work with that. And just one word about Synthroid. It says to give it on an empty stomach because it's highly protein bound and could be adhered to by the protein in the breakfast. However, I tell my patients just take it with all your other medications for simplicity, and then I'll go up on the dose if some of it is bound by protein. So I don't tend to order it on an empty stomach. So cognitive impairment increases the risk of older adults. And then we as providers may see fearfulness of the caregiver, poor eye contact with us, hesitation to talk openly with us. If the patient is having excessive depression or anxiety or insomnia, think maybe there's some abuse going on. And if the patient is dependent on the caregiver, that is also a red flag. As as we get older, dementia increases, and an 85-year-old person has about a 50% chance of having dementia. So when you're presenting patients and they're about 80 years old, always say this 80-year-old cognitively intact person or patient with dementia. It has a totally different approach if the patient has dementia than if they're cognitively intact. It has implications for their length of stay, for their discharge destination in the hospital, but also how we approach things with the patient when they're going back home or out of the office or from the hospital. So dementia makes it difficult for patients to collaborate and corroborate with any kind of reporting. And challenging behaviors with dementia can worsen the risk and increase the risk of abuse. And then there could be some legal issues with competency and capacity that could make things worse and lead to abuse, especially financial abuse. And then compassion abuse by the caregiver. If they're overwhelmed, if they're the only caregivers and don't have any break, maybe that puts them at higher risk then also. And many caregivers who are not very educated oftentimes think that the patient is much more capable of doing than what they are, and often say, well, she's just doing this on purpose, or she's falling on purpose to gain attention. So just clarifying that to the caregiver goes a long way. And don't argue with the patient with dementia. Oftentimes I see family members arguing with the patient when the patient says one thing because they just don't have a clue, and the family caregiver then corrects the patient and is arguing with the patient. So teaching the caregivers not to argue with the patient, just to go along with it, goes a long way. So trying to reduce problematic behaviors and just teaching the caregiver how to manage problematic behaviors can go a long way and is very, very important. So have you heard of hand over hand? Do you? Talked about it. Will that come later in the curriculum?
I don't know. We don't specifically talk about it. So.
Okay, yeah. As dementia progresses, the brain atrophies and there's less function and less control of the brain over the muscles that we use. However, the hand is hugely innervated. So if you remember the homunculus in the brain, the hand takes up a huge chunk of brain power. So as the brain cells atrophy, the hand is still highly innervated, even towards the end of life. And that's why older adults oftentimes clap or pat their hands on the table, because that's all that's left that they can do. And then approaching them with a handshake is hugely helpful. So let me pretend like you're a patient with dementia, and I reach out to you, and you automatically reach back. I didn't even have to tell you. It's just a natural reflex that we all do, including patients with dementia. Until the very end, they will reach back with their hand. So when I want to change your diaper now, I'm going to tell you, I'm going to change your diaper. But all you hear me say is, wah, 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 wah. And I approach your belt buckle, and you're going like, what are you doing, you know? So reaching out to your hand and then using that hand to guide you to the belt buckle is much less offensive to the patient and very, very helpful. So telling them, let's go eat lunch, using the hand is much more effective than if you say, let's eat lunch, because the instinct is to push back when you're getting pushed on the shoulder. So teaching that to families can go a long way in making keeping the peace at home. So making sure that the daily routine is consistent. If the patient gets agitated, if they get a bath in the evening, give a bath in the morning, or vice versa. Try to find out when the patient is tired and try not to challenge them with difficult tasks during that time. And make sure the patient is not too hot or too cold, or that they're not in pain. And that's something we can do something about. So the Wisconsin statutes want to make sure that patients are not put in a facility against their abilities. So if a patient can rehabilitate, they should be put into a rehabilitation facility. But likewise, if they cannot rehabilitate, then they might need to be put into a protective placement. So that's the statutes that came into being with that, and I think you have that in your curriculum in a little bit more detail. So when it comes to decision-making capacity, if patients cannot make decisions anymore, then it's up to us to identify that and also then say, well, it's time to turn over decision-making capacity to the healthcare power of attorney. So these are the 4 components of decision-making capacity. The patient has to understand the situation. They have to be able to weigh the options, relate the options to themselves, that is usually the most difficult one, and then communicate a choice. So I usually give a scenario of the medical problem that the patient has. For example, if she has shoulder pain, I will say, well, we can give you an injection in your shoulder, but it's pretty risky. There's a 1 in 10,000 risk of an infection with the injection. And what do you think? Do you think you would want that done? And then I would query her, well, how would it affect you? And usually patients then can tell me, yeah, so the risk is 1 in 10,000 because they remember that. But then oftentimes they cannot relate it back to them, how it would affect them or how it would improve their situation to get the shot, because that takes a lot of executive function to think that complex. So then oftentimes I declare the patient not capable of making decisions, especially complex medical decisions. By living arrangement, most elder abuse occurs in their own apartment, and second most common in housing with other family members. Less common in nursing homes, but that's highly regulated, so there's probably that number is pretty accurate or maybe even overreported. But then other settings are very underregulated, such as community-based residential facilities, BRFs, or assisted living and so on. So that might be also underreported. Physical findings, when we do a physical exam on a patient that we're suspecting of where abuse might have happened, is to look at weight loss, malnutrition, any vitamin deficiencies, then bleeding gums. That could mean poor oral hygiene or vitamin C deficiency, and then unexplained bruises, of course, especially bruises in different stages of healing. Now, many times our patients fall and fall frequently, and if it makes sense because they're bruised in places where they could have fallen, then that makes sense. But if there are bruises in different places, then have a high index of suspicion. And then pressure ulcers could mean neglect. So the location of the bruises in this question is the correct answer. Other physical findings could be contractures in patients with dementia. So if patients are not being moved very frequently enough, then contractures will set in because the stronger muscles will contract the joint in the position against the weaker muscles. If patients, for example, have an elevated TSH, even though they're supposedly on Synthroid, or if they have low INR on warfarin, that should raise the flag that maybe there is some neglect there and the patient is not getting the medications that they're supposed to. If they're missing their eyeglasses or their hearing aids, now oftentimes patients with dementia do lose them, but then putting a string around their neck that they can attach to the hearing aids can be helpful. And, the family is really supposed to keep up with that. So that might be a sign of neglect. Then malnutrition and dehydration, like in my patient's case, or poor hygiene also can be a sign of either self-neglect or neglect by the family. And then laboratory abnormalities. So in the assessment and plan, then, you want to describe any kind of apathy or depression or worsening dementia that could put the patient at higher risk of abuse, and a lack of compliance with medical regimens. And then explain, I'm suspecting that the patient is not compliant with the Synthroid because the TSH continues to be elevated despite escalation of medication doses, and so on. So although physicians are mandated to report, in most states, less than a quarter of reports come from us. Actually, most reports are coming from family members. And second, then, is medical professional. And when physicians were asked if they did report when they suspected elder abuse, 85% of them said, no, I did not report it when I suspected it. So I want to prevent that from happening to us here. So if you have a suspicion, contact social services and get them involved. And I'll give you a few tools on what we can do beyond that. In states with reporting laws where healthcare professionals are required to report, then the incidence is higher. And in all states, physicians are required to report if they see that the victim, if either the victim has told us that, or we've observed the abuse, or there is some injury suspicious of abuse. Then all states require reporting on that. But only some states require suspicions to be reported to. So and in some states, laypersons are also required to report. In Wisconsin, they are not. Only about 1 in 5 cases of mistreatment, either emotional or physical abuse, is being reported, but financial abuse is underreported at a much higher rate. And it's kind of a soft line because the older person oftentimes wants to help the family members out because they're living with them. So where do you draw the line, Competent elders have the right to live the way they want to. So even if they are being abused, oftentimes it's difficult to get them out of the situation because they have a right to stay where they want to. And oftentimes older adults are afraid to go to a facility, so they oftentimes want to stay in the abusive situation. And if that is the case, do not recommend that the victim leave before they're emotionally ready, because chances are that after they leave, because they're still emotionally attached to the abuser, they will go back into the situation, and many times that then leads to an escalation of the abuse and oftentimes death of the patient. So be very careful. Make sure that there are some resources in place, that it's reported to social services so they can come in to help support the family, and that we give them the opportunity to emotionally detach from the caregiver before they physically move out. Even in Wisconsin, healthcare providers are required to report in certain circumstances. So if a patient is cognitively deficient, so if they have dementia, then we are required to report because they cannot really make the decision for themselves. So anybody over 60 who has had sexual assault, bodily harm, or significant property loss, we're required to report because elderly patients are considered to be a frailer population and more at risk. And patients with mental disabilities, developmental delay, or dementia. And if the older adult requests that abuse be reported, then we definitely have to report it. And if the elder is not able to make a good judgment, or if they're not able to communicate, let's say they have aphasia from a stroke, for example, then we're also required to report if we're suspecting abuse. So the mandate is statewide, and each county has a ADRC or a Department of Social Services where we can report it to, and then that report has to be reacted upon within 24 hours, and an investigation must begin within 5 working days. So those are the laws. The most common investigating agency is the Health Services Department in Wisconsin. Second most common are the ADRCs, Aging and Disability Resource Centers, and then aging units, social service departments, and other agencies. Law enforcement is only a small proportion, but they sometimes also get contacted. So the goals of reporting abuse is to verify that there is some abuse going on, gather some information, and then develop a case plan. About a little bit over half are substantiated, but about a third of them are unsubstantiated. So, we don't really know. But it's always good to err on the side of reporting, and then it be found not to be substantiated. And always try to use the least disruptive action to maintain the patient in the least restrictive environment that they would like to live in. So start off with giving some caregiver support, supporting the family unit so that they can continue to live together if that's what the patient wants to do. So these are some screening questions for patients that we are suspecting might be abused. Are you afraid of anyone at home? Has anyone ever hurt you or taken from you? Do you feel safe where you live? Does anyone make you afraid? Has anyone scolded you or threatened you? Have you ever signed a document that you did not understand? Or have you been kept from your friends or acquaintances that you would like to see? These are some tools for screening, and they have various different time requirements. The EASY, EASI, is the shortest one and probably the most practical one for us in the clinics or in the hospital settings, wherever you may practice. It does not have that great of a sensitivity, a little bit better specificity, but not that great. The best one is the EIOA. However, it takes more than 2 hours to administer. So, of course, the more detailed the screening, the better you yield, but then the more time it takes. So it just depends on how big your suspicion is. So this is the EASY. It's available online for free. You can just Google it and print it out and administer it in your practice. The Vulnerability Assessment Score of the aged person screens patients who might be at risk of abuse. So that's a nice resource to have. And then the Caregiver Self-Assessment Questionnaire. I have given that to some caregivers in my practice before where I was suspicious of some stress in the family, because it's better to preempt it and give the caregiver some support and say, it takes 70 to 110 hours to take care of a patient with dementia. It's very stressful. I understand. So let me give you this caregiver stress questionnaire and see if you are being stressed. And if you are, maybe we can give you some support, maybe some respite time, maybe some hours each day to help defray all that stress. And that opens up the door for them to communicate with you and maybe prevent abuse. The Caregiver Strain Index is another tool that is available online. And then let's talk a little bit about documentation. That's really important. Usually when you're suspicious of abuse, this might go to court, so it's really, really critical that you know how to document it very accurately and very properly so that the case will stand in court. So in the history, you want to describe the chain of events, what led up to the abuse, and be very precise and very thorough. Try to describe it in the patient's own words and then say the caregiver's explanation. Try to be as verbatim as you possibly can and put that into quotation marks. And in the history, subjective, the history, the first part, only things that the patient or the caregiver say go in and not what we interpret. That goes into the assessment and plan. So be very strict about that. And then document a complete medical history, relevant social history, and then a description of the injuries. And then only in the assessment and plan goes your interpretation of saying this might be suspicious of abuse. Because if you put that into the subjective, then a lawyer might say, well, you had a vendetta against my client because you already thought before you ever examined the patient that there might be some abuse going on. So be very clear of where you document what. Try to be as specific as you can with the words of the patient and the caregiver in the subjective. Be as objective as you can in the objective, in the physical exam portion with the findings. The bruise was 5 centimeters in diameter on the right forearm or whatever. And only put your interpretation of the situation in the assessment plan, not in the objective, not in the subjective. And then, if necessary, get some labs to support that the patient may not have taken their medication, and so on. And x-rays if you think there might be a fracture. So safety assessment: is the patient in immediate danger? If you think that they are, then maybe we need to intervene right away. But what can we do to increase the safety if the patient is not in immediate danger? Provide community resources, maybe getting a Hoyer lift so that the patient's caregiver doesn't have so much lifting to do and doesn't get as aggravated with the patient when they're trying to lift them. And then just social support. Maybe rally the church community around them or other community resources that are available. Obtain home health services. Maybe sending the patient to adult daycare for 6 hours a day might decompress the situation sufficiently to where the caregiver gets enough of a break and then has enough energy again. Then getting other family members involved. It might be helpful for us as physicians to call up the other child or the nephew or grandson to help out with the caregiving. Because the primary caregiver may not have the authority to say, well, I need some help, or may not have the self-confidence to speak up. So having us step in might be helpful for them. But, communicate with the caregiver and make sure that it's okay with them for us to step in there. And then caregiver training can go a long way. If the caregiver understands that this dementia is not willful, volitional aggression against the caregiver, can go a long way. Then sending the patient or the caregiver to AA or the family members to Al-Anon is critically important, particularly in Wisconsin. High rate of alcohol abuse. So having Al-Anon in the back of your mind, even if the alcoholic does not go to AA, Al-Anon can be tremendously helpful for the family members because alcoholism is a family disease. Then managing depression in the patient can also go a long way, and simplifying medications. Then doing a home safety evaluation. It might reduce the falls if the furniture is rearranged a little bit differently so that the patient can go from one furniture piece to another. Obtaining necessary medical equipment, maybe a rollator or a walker, and so on. And then doing capacity evaluation if necessary. And if necessary, move the patient to an assisted living facility or from a group home to a nursing home if their needs have increased. If families then are looking at placement to a facility, this is a questionnaire for patients and families to ask of the facilities that you can Google and also hand to the families in their search for a suitable facility. A Place for Mom is also a nice resource for assisted living facility visits, assisted living facilities where they find a suitable facility for the needs of the patient. So have a high index of suspicion for abuse. The most common form is neglect. The incidence is increasing, and healthcare providers are required to report. And that's the website for Wisconsin. Any comments or questions?
I have a question question for you. Irene, can you speak a little bit about your approach to families when you're seeing a decline and you think that the next step would be either nursing home or assisted living, and how you start that or continue that conversation with family members?
When a patient is declining from dementia, the decline goes in the reverse order that child development happens. So patients usually first cannot urinate, cannot keep their urine anymore, then they lose the ability to dress and to walk and so on. So as the decline happens, I tend to give my family some anticipatory guidance and say, the dementia has robbed them of their ability to hold their urine. The next step might be their ability to walk. So as I give them anticipatory guidance, I also query them, and I'll say most patients are cared for in the home, but about a third of patients are cared for in nursing homes. And if that's the case, then let's talk about what you would like in a facility. And I also inform them early on in the disease process about Medicaid requirements, because most families don't have enough assets to pay for nursing home care or assisted living facility care out of pocket. And then the patient has to reach spend down and qualify for Medicaid. And being knowledgeable about the requirements under Medicaid in each state, which is state administered, is very critical for us so that we can guide our families. And Medicaid looks back about 5 years, so families have to get rid of some assets, if there are some assets that they want to keep, for 5 years before Medicaid kicks in. But just giving them some guidance of what to expect, and to say, many patients really enjoy assisted living facilities because they can communicate with other people. They're not alone at home anymore. The other thing I do with them in anticipation of decline of dementia is encourage families to to write down a letter that states, when my daughter, Michelle, gives me this letter, it is time to turn decision-making capacity over to her, and put down the healthcare power of attorney in that letter and the secondary healthcare power of attorney, or anybody else that's in the family that they would want to trust and give that letter to. And that's very helpful for the families then to have when the patient, for example, is not able to drive anymore. Then they can give them the letter and say, it's time for you to give up your driving because you're not able to make decisions of your own anymore. And because they see the signature, their own signature at the bottom of the letter, it goes a long way to make it much easier for the family. Did that answer your question?
Yeah, that's great.
Any other comments or questions? Have you ever encountered any abuse? Yeah.
I think it's really hard. For families, especially if there's spouses that are living together and they're both involved in some form of self-neglect, for that to be labeled as abuse, especially in the family. So, do you have any tips when the self-neglect is going on and how to navigate that?
It's very, very challenging. And I said that early in my talk, too, that if the patients are cognitively intact, there's nothing you can do. They have a right to live in the squalor that they choose to live. And as long as there is no harm being done, I guess they're stimulating their immune system. So I don't know. It's very, very hard. And in my experience, when there is a self-neglect, when there is interference by the family, not only does it fracture the family bonds then, but it doesn't change the situation, because if they clean up the house, a few weeks or months later, it'll look the same. So if the patient is cognitively intact, I usually recommend not doing anything about it. But if there is harm being done, then we do have to step in. And maybe if the patient is still cognitively intact, they have some insight then into the adverse outcomes. Mm-hmm. If the patient is not cognitively intact and they do need placement, then the healthcare power of attorney, or if there is no healthcare power of attorney, then the legal guardian that's assigned has to make that decision for placement. But oftentimes these patients continue to hoard in the facilities. And then their room just is overflowing. So it doesn't go away. It's just kind of managed. Did you have a case? Okay.
Not with elder abuse, but I had to report abuse to
Speak in the microphone, please.
when I was a floor nurse, I had to report a case where there was a patient's husband, and they were foster parents for like severely mentally handicapped people. And I was sitting at the nurse's station across the room, and I saw the husband was feeding this boy, and he, I don't know if he like drooled or spit it out, but he slapped him across the face. And I saw it, so I had to report that.
Yeah. Wow. What ended up happening?
I mean, I think eventually, I don't know if he got probably taken away from his family, but the social services were there, CPS was there.
Yeah. Yeah, it goes back to, caregivers not understanding the ability of the patient. Yeah. Yes.
So if a patient is cognitively intact, even if they're in an abusive situation, if they want to stay there, and we've discussed it with them, we don't report that then. Is that right?
Right, yeah.
Okay.
Because if they're cognitively intact, they have the right to do that. And, the literature also bears out that it is more dangerous to remove them from the situation because oftentimes then they go back later on. Yeah. So they really have to make that decision themselves to leave.
Okay.
And there are resources available that we can give them and get them plugged in and have them come back to our office to work on this issue and see how we can support them and build their self-esteem so that they then get the energy and the self-confidence to leave. Yeah.
So if you do suspect abuse, but they don't want anything done, and they're cognitively intact, do you still include that in your documentation as far
Yeah.
as like in your assessment plan, being like, I suspect this, but the patient is not going through anything?
Yeah, and that can be quite dangerous too because sometimes the caregivers will have access to the chart, like through my chart, and force the patient to let them view it. So if you are suspicious of that, then maybe hide that note. But I would still encourage you to document it, but maybe make it so that it's not accessible.
I'll just add that
I've seen several, because I work in geriatrics, several cases of self-neglect, definitely, and a couple of cases where we suspected physical abuse.
I think the most
Difficult one to pinpoint
as healthcare providers is financial abuse.
Yeah.
And
that has only come up.
lucky enough to work with a geriatric social worker, which if you
Have access to a social worker,
that's huge,
but a lot of places you don't in primary care, unfortunately. But I think that's,
much more prevalent than we know.
but it's also not something that's likely to come up.
Through the course of you could be suspicious, but it's a little bit harder to document that in the course of a medical visit.
Exactly, yeah. I've had one case of financial exploitation, but I've had several cases of substance abuse and substance diversion where family members will take the medications, the narcotic medications of the patient, and then the patient comes back talking about pain, and I'm suspicious, and I oftentimes get a drug screen to make sure that the patient is taking it. So, those are delicate situations. And one patient actually told me that her daughter was selling the drugs. So what do you do then? Because the patient still needs medications. It's a difficult situation. And I don't claim to have the answers. Yeah.
In situations like that where you need to get labs or talk to the patient, I know you mentioned having the caregiver step out for a bit. How do you address that, or how do you explain, we're going to get a urine sample, without, I don't know, flagging the caregiver of why you're doing something like that?
Well, Oftentimes I just don't explain why I'm getting the urine. I just say, we need to get a urine sample, And many times patients are incontinent, then you could say, the patient is incontinent, let's get a urine sample. And that's it, But if they really are asking, then I might just be honest, especially after I got the sample, I just don't want to thwart getting the sample from the patient in case they do something, or take the patient away before she has a chance to go to the bathroom. But usually that's not the case. That's not an issue.
Just add to that, say we recently started in the clinic where I work a pain contract situation where everybody was on. And at first, in that policy, we weren't going to include older adults. So I can't remember what the cutoff was, but anyone who's been on chronic opioid therapy and they haven't asked for an increase recently, they were going to be excluded from the pain contract. And part of that pain contract is random drug screens, no getting early refills, not billing from multiple providers, a lot of things that are becoming more common with the opioid problems. And not just me, but others also really advocated not to exclude older adults because with that pain contract and those policies in place, then you have the ability to fall back and say, we're not singling you out. We do this for all of our patients who are on pain medications, and as part of there's a big education component to that pain contract, and one of the things we talk about is this is for your safety as well as our safety, and it's not punitive, and it's really to make the whole process easier for everybody. Because what the problems that I would see, and I'm sure Dr. Hamrick has had this too, is you have a patient who's coming in who seems reasonably able to say whether or not they're having pain, and who's reporting that their pain is stable, but their family members are constantly calling the nurses to say, my mom is in so much pain, she needs a higher dose of fentanyl, she needs more PRNs, and if you don't have that, kind of regimented policy about pain medications and you exclude that population, then you don't have that standing to fall back on.
Yeah, excellent point.
Right. Thank you so much.
Thank you.